Thank you. But host has disabled me and I can't share my screen, it seems. Hi, Kumarjit, good friend of mine. We are batchmate and we have done our MBBS together from Regional Institute of Medical Science in Manipur. By the time, hopefully our host will allow, yeah, he has finally allowed me to, in our younger days. Anyway, coming back to the serious things. So we'll be discussing mostly on the ventilation management of ARDS. And I would like to make it very clear from the beginning that despite the contrary to the claims, the management of ventilatory management of coronaviral disease is not different from other types of hypoxemic respiratory failure. And we have done a lot of mistakes while managing the coronavirus patients because we were overwhelmed by the pandemic and our resources were absolutely constrained. And that led us to doing a lot of mistakes. But we now realize it very clearly from different studies that it is not different from other types of hypoxemic respiratory failure. So back almost 50 years back, half a century ago, Eshbo and his colleagues described 12 patients. Interestingly, these papers, they sent this paper to NEJM, it was rejected there. They sent the paper to American College of Surgeons, this Journal of American College of Surgery, it was rejected there. Finally, it was accepted in Lancet, and it was published on 12th of August, 1967. They described a phenotype, 12 patients who all presented with dyspnea, tachypnea, refractory hypoxia, bilateral lung infiltrate, and decreased lung compliance. 7 of these 12 patients, they died with an overall mortality of around 58%. And when they did an autopsy of these patients, they found that all these patients have profound alveolar atelectasis, diffuse alveolar hemorrhage, and hyaline membrane, resembling the neonatal respiratory distress syndrome. And they named this as adult or acute respiratory distress syndrome. Initially, it was adult respiratory distress syndrome. Later on, it was named acute respiratory distress syndrome. So this is how the ARDS came into the picture. Later on, but we must remember ARDS is not a disease. ARDS is just a syndrome which presents with certain phenotypes. But we other than doctors, we are also researchers. So we need to define the syndrome because otherwise we can't produce published papers. So the paper was we started defining it. And in 1988, Dr. Mare described the first lung injury score. Dr. Mare recently died because of COVID at the age of 94 last year in 2020. Later on, the European American Consensus Conference gave us a definition of ARDS, a more refined definition, and latest definition came in 2011, which was published in JAMA in 2012, called Berlin definition. That definition has got 4 components to it. What is different from the previous definition of 1994 is this definition has given us a timing. They told us that the timing is very important. The ARDS, to define ARDS, we need to have a known clinical insult, and that has to be there within 1 week. The chest imaging must show a bilateral opacities which cannot be explained fully by effusion, collapse, or nodule. This is different from the 1994 definition, which only said the bilateral opacities. And the origin of edema cannot be completely explained by heart failure or fluid overload. And this needs to be assessed objectively by echocardiography. They also gave us a oxygenation criteria, which is defined as a PaO2 and FiO2 ratio of less than 300 with a PEEP, remember, with a PEEP or CPAP of more than 5 centimeters of water. That is the exact definition of ARDS as given by the Berlin conference. So with this definition, if you go, what is the global problem? They did a study called Lung Safe study, which was published in JAMA recently, I think 2-3 years back. And they found that around 10.4% of the ICU admission could be defined as ARDS in some point of time. And overall, 1/4 of the patients who required mechanical ventilation in intensive care unit, they had a definition of ARDS fulfilled, with a mortality of 35.3% in the ICU and the overall 40% ICU mortality. They also found that with the severity of ARDS, the mortality increases. They also found that with the severity of ARDS, the ventilator discontinuation rate decreases. So ARDS, they found that it's very common, and it increased the mortality. Now let me come to a case. So we all know the Berlin definition. 24-year-old man who presented to us with history of fever for 4 days, dry cough for 4 days, progressive shortness of breath for 2 days, and which increases since last morning. He was dull, but obeying simple command. He was visibly breathless. He had a temperature of 102, heart rate of 124, BP of 84/46. He had a capillary refill time of more than 6 seconds with a respiratory rate of 32. He was hypoxic, maintaining 90% saturation on 60% venturi mask. And he had bilateral scattered crabs on lung auscultation. And this was the chest X-ray. Can you call it a ARDS? See, this patient definitely fulfills his hypoxic, but we do not have an ABG in place. When I was doing my internship and house job in medicine back in 95, 96 in GB Pant Hospital in Agartala, we didn't have a single ABG machine in place. As a matter of fact, we didn't have a single ventilator in place. Does it mean that we should not treat these patients just because it does not fulfill the criteria of ARDS? No, not. Very recently, I have served in Indian Navy at Port Blair. We didn't have any ABG machine in our hospital. We had some ventilator. So just to give a different sort of flavor to the things. So there was a modification of Berlin definition for resource limited setting called Kigali modification, which is more useful for us working in more resource constrained situation, or in the emergency department where the patient still did not have any ABG, or patient is still not on ventilator to fulfill the PEEP criteria. So in Berlin, in the Kigali modification, and by the way, Kigali is a small town in Rwanda, in North Africa. They, instead of chest imaging, they used USG chest. USG is much easily available, and anybody can be trained in USG in 24 hours time, not even more than 24 hours, to see the artifacts in the chest. They also modified the oxygenation criteria and used SpO2 and FiO2 ratio instead of the PaO2 and FiO2 ratio. They defined it as SpO2 and FiO2 ratio of less than 315, and they did not require any PEEP. And by this, they found that 4% of the hospital admission had ARDS, even in underdeveloped and LMIC countries, requiring a huge number of ICU admission and a hospital mortality of around 50%. So my dear friend, it's a lecture on, it's a conference of clinical medicine. So I would like to emphasize the fact on, do we actually require these definitions? Do we actually require this ARDS at all? What we need is, what is the definition? What is the diagnosis for my patient? The basic diagnosis is not ARDS. The basic diagnosis is pneumonia. So we have to treat the patient with antibiotics. How do I manage oxygenation to support the condition? And to manage the oxygenation, we do not require a definition of ARDS. It can be anything. Any hypoxemic respiratory failure is treated in the same manner. My third question is, how do I optimize this support? And my final question is, how do I maintain the perfusion? This patient was hypotensive and he had a prolonged CRT, irrespective of the definition of ARDS or not. So my dear friend, this slide I made, modified from the original lecture of Professor Ranieri in 2011. So based on this, if we see the treatment of maintaining oxygenation, we start with low flow oxygen. That can be a nasal prong, or it can be a mask, or it can be a non-invasive ventilatory support. Once the patient does not fulfill that, the patient does not maintain his oxygenation with that, we move on to the invasive ventilation. We give some PEEP, either a low to moderate PEEP or a high PEEP. We prone these patients. Sometimes we use neuromuscular blocking agents. And finally, we go for ECMO. Anyway, I'll limit myself to more basic things today. Now, what about low flow oxygen, HFO, and NIV? I must say we have abused a lot these measures during the COVID pandemics. A lot of patients were kept on low flow oxygen, NIV, and HFO, high flow nasal cannula, for a very long period of time. This study, which was published in New England Journal of Medicine in 2015 from 23 ICUs of France and Belgium, they treated 310 patients of hypoxemic respiratory failure, either with HFNO, high flow nasal cannula, or with non-invasive positive pressure ventilation, or with standard oxygen. And they found the non-invasive positive pressure ventilation actually increases mortality compared to HFNO and standard oxygen. Does it mean that we should not use non-invasive ventilation? It is like, what is the best way to prevent pregnancy? Abstain from sex. That does not mean that we should not use this. That only means that we should be cautious, start with low flow oxygen, nasal prong, or some mask, or we can switch over to some HFNO or NIV, but we should be cautious and we should be monitoring the patient clinically. And what we are supposed to monitor, the most important thing to monitor is the respiratory rate. The higher the rate, the higher the chance that patient will fail these non-invasive strategies. So this was a very old study published in 1988, where they found that the simply just respiratory rate, increase in the respiratory rate itself can produce changes like ARDS. So be careful. I suggest anybody who is on a low flow oxygen or high flow nasal cannula or non-invasive ventilation, and if he or she is breathing at the rate of 35 breaths per minute or more, it is time to intubate these patients. Similarly, if the patient is generating a huge tidal volume, it is time to intubate this patient. As can be seen from this study published in Critical Care Medicine in 2016, where they found that a patient who is generating a tidal volume of more than 9.5 ml per kg, there is a very high chance that this will fail the non-invasive ventilatory supports. So these are the patients who needs to be intubated. If you want to read more about this particular topic, in 2019, there is a chapter published by me in Critical Care Update. You can go through it. It'll give you more insight into it. So I suggest in a patients of ARDS with a PF ratio of more than 150, PaO2 and FiO2 ratio of more than 150, or we can say the SpO2 and FiO2 ratio of more than 200, you can give a trial of either low flow oxygen or high flow oxygen or non-invasive ventilation, but keep a very close eye. If the respiratory rate is more than 35 or there is a high tidal volume of more than 9.5 ml per kg, please do not delay intubation. Intubate these patients and apply lung protective ventilation with the aim to maintain the oxygenation. If the patient has a PF ratio of less than 150, do not delay intubation. Please intubate. Okay, so coming to the invasive ventilation itself, invasive ventilation is a trade-off between maintaining oxygenation and ventilator-induced lung injury. Whenever you intubate the patient, there is a risk of ventilator-induced lung injury. So we make a trade-off. We balance between these two. So ventilator-induced lung injury can be produced either because of the pressure effect, which is related to the transpulmonary pressure swings, which is more in non-invasive ventilator. It can be because of the volume effect. Again, it is more common when the patient is generating high tidal volume. It is due to the effect of high rate of pressurization, which is again related to the respiratory rate. As I told you earlier, the more the respiratory rate, higher is the risk of ventilator-induced lung injury and even patient self-induced lung injury. Effect of cycling opening and collapse of lung tissue, which we call atelectotrauma, and the inhomogeneity of the lung itself, which is also known as the baby lung concept. So my dear friends, remember, we are making a balance between the risk of invasive ventilation and maintaining the oxygenation itself. So it's a trade-off. I believe if the PF ratio is less than 150, it is better to intubate this patient and put the patient on invasive ventilation. If the respiratory rate is more than 35, or if the tidal volume is more than 9.5 ml per kg body weight, again, it is better. The benefit of invasive ventilation outweighs the risk. Now, how do we do that? So I talked about the lung protective ventilation. It means that we have to limit the lung strain. We have to limit the lung strain by reducing the tidal volume. The tidal volume has to be around 6 ml per kg body weight, but you can go up to 8 ml per kg body weight in certain circumstances. And how do you, this per kg body weight is the per kg of the predicted body weight. And you calculate that predicted body weight based on the height of the patient and sex of the individual. So for the first 5 feet, for a male, the predicted body weight is 50 kg. For a female, it is 45.5 kg. After that, every 1 inch increase in the height, increase the body weight by 2.3 kg. So this is how you calculate the predicted body weight. Once you calculate the predicted body weight, you can calculate the tidal volume at 6 ml per kg body weight. Limit the lung stress. Keep the plateau pressure below 30 centimeter of water. I'll tell you how to measure the plateau pressure. Prevent the atelectotrauma by using appropriate PEEP. I'll tell you how to define the appropriate PEEP. And our goal is to maintain the minimal oxygenation target, not the maximal oxygenation target. So keep a FiO2, PaO2 of around 55 millimeter of mercury. You don't have to have a PaO2 of 100% or 100 millimeter of mercury. Just keep around 55 millimeter of mercury. Keep an SpO2 of 88 to 95%. That's it. In this way, you can...
SUPRADIP, just to meet a gentle reminder, we are a little bit short of time. So if you can finish a little bit early. Can you hear me?
I can stop here. I was given a time of around 30 minutes. I can stop here, no problem.
No. I mean, it's okay. I mean, a little bit short of time. So
I'm okay. I can stop here, no problem.
No, you can continue. I mean, to make it a little bit short.
30 minutes is the time which was given to me as far to the best of my understanding. Am I right?
Yes.
And I think I'm done only 12 minutes or maybe less. It is okay.
Okay, actually.
Marjit, no problem.
No. You can continue, but make it a little bit short. Thank you so much. Little bit short.
Okay. Anyway, so this is the plateau pressure, and you have to measure the plateau pressure by putting an end inspiratory pause for for around 4 seconds, and you need to keep the plateau pressure below 30 centimeter of water. And we have a lot of evidence. We have evidence from the ARMA trial, which was published in ANIGEM in 2000, which has showed that we have a huge benefit of going for this lung predictive ventilation. We need to go for a PEEP. Where PEEP have an open lung strategy. To maintain the open lung strategy, PEEP is beneficial, but PEEP, on the other hand, can also produce barotrauma, atelectotrauma, and worsening of the VILI. These are the studies which are published on PEEP and different PEEP strategies. They did not find any benefit of any PEEP strategy over another. So what I suggest is you have to individualize the PEEP, higher PEEP for patients with worse oxygenation, avoid hemodynamic compromise, look for bedside echocardiography to see whether the PEEP is getting over the counter or not. Okay. Early proning can be beneficial. This has been shown in the landmark crossover trial published in 2013 and ANIGEM, which has showed an improved 28-day and 90-day mortality. So this is how you have to prone the patient. But you need to have a closer look at the monitor to look for different asynchronies and dysynchronies. And so to summarize, most important thing is to establish the etiology and appropriate treatment. A thoughtful hemodynamic resuscitation is required. Do not drown the patient with fluid, which is very, very common. Universal care of critically ill with fast-track infection control practices. Do not delay intubation. Maintain a lung protective ventilation. Maintain permissive hypercapnia with a low target. Maintain light sedation, judicious use of NMBA, and early proning. Thank you very much. I thank the organizer for inviting me for this session. Thank you very much.